Okay, so we start the debate. Maybe that you, Serge Vertosek, you can come here to the podium, to the desk. Just because we want to debate at this point, what is the position, which is the position of JAK inhibitors as second-line therapy in patients with PV who are intolerant to hydroxyurea? You know that ELN produced a recommendation. First of all, you had to follow WHO 2008 for diagnosis. Second, all patients should be phlebotomized to reach an hematocrit less than 45% and given aspirin 100 milligrams a day. So this is based on 2 clinical trials. So this is a very, very solid recommendation. If patients present poor compliance to phlebotomy or progressive myeloproliferation, you realize that this is due to splenomegaly, leukocytosis, thrombocytosis, or if patients present with higher risk features such as age, over 65, and prior thrombosis, then you have to consider cytoreductive therapy. First line is hydroxyurea. The ELN accepted interferon as a first line in a younger patient. Second line therapy after failing hydroxyurea can be interferon, and vice versa. After interferon failure, you can use hydroxyurea. In elderly, you can use also busulfan. The problem here is that when patients are treated with hydroxyurea, not all these patients can have a response, or they can lose the response, or they could be intolerant. And there is a definition, again, by the ELN, when you give 2 grams of hemoglobin a day, of hydroxyurea a day, you still need a phlebotomy, or you cannot correct leukocytosis or thrombocytosis, or you cannot correct the splenomegaly. This patient can be considered resistant. Is also intolerant when at the minimal dose of hydroxyurea, you still have leukopenia, neutropenia. So in this case, you can say, my patient is intolerant. Another point that should be considered is that some patients can present lung ulcer, and sometimes you have toxicity in other organ, for instance, in GI or pneumonitis. So these patients can be considered resistant or intolerant. How many are there? In this study done by Alberto Alvarez Salran in Spain and published some years ago in the Blood, they were able to recognize 11% patients with resistance and 13% intolerance. These patients had a bad destiny in terms of overall survival and transformation toward myelofibrosis. It means that hydroxyurea select a subpopulation of patients that corresponds 10% of the entire population, and their outcome is quite poor. So you need to treat with a new drug. What about the JAK2 inhibitors? We know that JAK2 inhibitors have been tested in polycythemia vera, in resistant or intolerance patient to hydroxyurea, I have to say that the only drug that is now approved by FDA and EMA is Ruxolitinib. So you can use it in clinical practice. And this is based on two studies. The first is based on the study by Surge, phase 2 study. They did a study, we did a study, and showing that CR are presented in a great proportion of patients, and PR as well. So at the end of this trial, it was decided that these results deserved to be tested in a randomized clinical trial. And a randomized clinical trial is the response. Look at the inclusion criteria that corresponds to the definition, and look also that pre-randomization patients were kept at the hematocrit less than 45 by phlebotomy, and then they were randomized to the drug or the best available treatment. At this point, some patients can be in the arm, Ruxolitinib arm, could be crossover to that. So the response primary endpoint was a composite endpoint, including the percentage of patients with hematocrit, normal hematocrit, without phlebotomy. And the second composite endpoint was the spleen reduction, less than 35% with MRI. That corresponds 50% by palpation. Primary endpoint, the composite endpoint, was achieved in this proportion, 21% of patients, as compared with nothing in the best available treatment. And if you select the two components of the primary endpoint, this is very interesting, because you have here the reduction of the spleen in a good proportion of patients, but very, very important also is the no need of phlebotomy when you treat your patients with Ruxolitinib. This is a very important thing in polycythemia vera, if you don't need to phlebotomize your patients. And considering only complete hematological response, meaning everything normal, granulocyte, leukocyte, of course, no phlebotomy need, and the leukocyte and platelets, this is the number. You reach in 50%, 55%, you reach this endpoint, complete hematological response. Notably, the improvement also in symptoms. You can divide the symptoms according to those derived from cytokine increment, or hyperviscosity, or splenomegaly-due symptoms. And you see here, in each of these categories, you get a better performance by the drug as compared with the best available treatment. Important is also, and this deserves to be discussed, is that the rate of thromboembolic event. Notice here we are after 6 months, 32 weeks. The rate of thromboembolic events or more was lower in the Ruxolitinib arm as compared with, but I want you to notice, as I said, we have to discuss this point. 1 versus 6. Numbers are too limited, but you have to register this. You have to pay something in terms of toxicity. I would say that the major toxicity that distinguishes Ruxolitinib versus the best available treatment is the viral toxicity, especially herpes. You have 7 cases here against no cases in the best available treatment. So, in conclusion, having said that, what is my position? How I treat a patient with a PV today in 2015? Of course, I divided the patients in low, high risk. Remember that all patients should be addressed and tested for vascular risk factors, because the main problem for this patient is thrombosis. So you have to avoid the thrombosis. If you are at high-risk patients and you treat, as I said at the beginning, with the ELN recommendation, at a certain point, you have a patient that still have symptomatology, resistance, refractory, that could be in a proportion of 10 to 20 patients after hydroxyurea. Then you have to consider today Ruxolitinib or to enroll your patients in new clinical trials. So this is my point, Mr. Opponent. Now is your turn.
Okay. That was a really great summary. Thank you very much. Not much to debate, but there is something to debate, so we will debate. So the question is strictly for hydroxyurea-resistant intolerant patients, right? And that was the definition that we have developed all together and which was implemented in a clinical study. So that's the point of contention. Let's see. Okay. You led the effort several years ago in modifying recommendations for cytotoxic therapy in PV, and one of the major additions were in the red box to control systemic symptoms, because we realized that patients can have a normal blood cell count and still have a lot of symptoms. We do see this quite often, actually. And therefore, we said we need to control those symptoms as a goal of therapy, in addition to others, right? To treat complications, thrombosis, hemorrhage, and others, as is normally known. And therefore, the guidelines are including several aspects. And in addition, for the patients that are younger and did not have a prior history of thrombosis, we can introduce cytotoxic regimen if they have poor tolerance to phlebotomy and again have symptomatic progressive splenomegaly or severe disease-related symptoms. So you have symptoms all over the place because we know that we want patients to enjoy good quality of life. So the goals, according to European Leukemia Net, when you start therapy, is to achieve complete response if possible by looking at 5 factors: blood cell count on all 3 lineages, normal spleen, as well as no disease-related symptoms. And partial response is defined in the lower part. So far, everything goes along the same premise that we should look at the person, not just at the numbers, not just at the spleen, symptoms, good quality of life, prevention of these things by introduction of the therapy. So how effective is hydroxyurea in this setting? This is from the Spanish study. We have actually our colleague from Spain here that will talk tomorrow on this particular topic. And we are able to completely normalize all the 5 factors in only a quarter of the patients. We all agree that about 10 to 15, maybe 20% of the patients, depends on a study, there are patients that are intolerant, resistant, or do not respond, and here it was 10%. What is the PR? That's partial response, suboptimal response, which is the largest group. So we are doing some good, but not all the good that we would like to provide. And then we come up with definitions of clinical resistance and intolerance, and that's the exact slide that you showed. But something is missing here. We have a target 1, 2, 3, as you see in this table, and we look at the phlebotomy as the most important factor, then look at platelets and white cells and spleen in decreasing significance as per experts. There is no word about symptoms. What about patients that have normal counts and have itching every day and can't take a shower? Or patients that have other symptomatic problems from polycythemia vera but have a normal counts? Or patients that have a normal counts and have a blood clot, have a DVT on therapy with normal counts. They are not mentioned here as resistant to therapy. Do we continue therapy with hydroxyurea because the definitions do not include that? I would argue no. That's a failing therapy that allows patients to have a blood clot when the count is normal. So these two things are missing. Now, you showed this as well, and we fully agree that these patients, for some reason, unknown to us, do have more aggressive disease. I think it's perhaps biologically more complicated. We don't really understand it. But if they don't do well on hydrea, they will not do well overall. They have high risk of transformation and high risk of earlier death. But patients, regardless of the state where they are, suffer from different symptoms. And this is a very instructive paper published by Dr. Ruben Mesa and colleagues from Mayo Clinic in Scottsdale on the presence of different symptoms in detail, as you can see, in patients with different myeloproliferative neoplasms and comparing patients with ETPV and myelofibrosis one to each other. And it's quite striking that patients with the lower grades of MPN, which we define as benign most of the time, have almost close, I would say, to the same extent systemic symptoms that myelofibrosis patients have in general. And then, and this was another study from Dr. Ruben Mesa, when you look at the patients who are on hydrea, this is patients with PV only, patients on hydrea versus no hydrea. This is a rather complicated slide, but look at the first line. Patients on a hydrea, patients requiring phlebotomy, yes, no, spleen, yes, no, all features, hardly any difference here in symptomatology. So symptoms do bother patients in the large scale across the board, regardless of whether they are or they are not resistant, intolerant, or have a big spleen or not have a big spleen. And with Ruxolitinib, as you elegantly pointed out already, in addition to normalizing the blood cell count and producing 24% complete response rate in that study and normalizing the spleen, you have significant, very significant, and this is much more in detail that was shown before, one by one, the most common symptoms that patients with PV suffer. You see that this is significant relief for many patients. And in particular, one of the circled symptoms, the number 2, is itching. Itching resolves in about 95% of the patients. So it's within a couple of weeks. So it's a very potent anti-inflammatory medication in addition to controlling the blood cell count. Therefore, I welcome the addition of Ruxolitinib to medications that we can use as a cytoreductive therapy in polycythemia vera. And I do not touch the first part of the slide, the frontline recommendations. But in the second line, Ruxolitinib certainly can be useful. And look at what the definition for its use by FDA is. It says inadequate response. It's not strictly resistant or refractory to hydrea. It's inadequate response or intolerant. So it's inadequate by the judgment call of the physician, not whether the white cell count is less than 10 or platelets are less than 400 or a spleen and so on. It doesn't really go to this detail. And to my satisfaction, inadequate response for me is also a patient who has been on cytoreductive therapy with normal counts and has significant symptoms that are not controlled. I would certainly consider that patient for an alternative, and ruxolitinib now comes handy. And therefore, my possible algorithm for therapy of PV at this point in time is this one. We look at all those risk factors at the beginning once we confirm diagnosis and look at the symptoms as well. We do phlebotomy and low-dose aspirin and then decide on cytoreductive therapy. We look at progression in the disease characteristics, vascular events, and symptom burden, as well as blood cell count. And if these are not controlled with the frontline cytoreductive therapy, then I would consider ruxolitinib. Not strictly resistant or refractory hydroxyurea as per definitions. Lovely debate, thank you.